Hello and a warm welcome to this third session of the NPC 2021 Virtual Annual Conference. I'm Jan Short, General Secretary of the National Pensioners Convention, and today I will be chairing what is crucially an important discussion on the subject which has come to dominate our COVID-19 pandemic debate. That is, who cares about the future of UK health and care? Now, to discuss the issues involved, the NPC is delighted to welcome three expert guest speakers on health and care. And first of all, we will have John Bosco Wubo, who is a campaign officer with the watchdog We Own It, with whom we partner on lots of campaigns. Professor Sir Michael Marmot, the internationally recognised expert in health and care, and advisor to the World Health Organization. Now he'll join us at 2:30. And Tracy Jarrett, who is manager of the Lewisham Pensioners Forum. So those are the introductions done. I'd like to hand over to Jonathan Safer, who's our information officer, and he's going to tell you how we'll manage the webinar and explain the format. So over to you, Jonathan.
Thank you very much. As Jan said, I'm Jonathan Safer, Information Officer for the NPC. I'll be hosting the event along with Bev Morrison, our Campaign Officer, and doing all the technical aspects. If you have any questions that you would like to put to our panelists, whether you think of them at the time or later on in the session, please use the Q&A function. You should find it at the bottom of your screen. It just says Q&A, and type your questions in there and we'll try and get round to them. In the last few webinars we've had quite a few questions and we haven't been able to answer all of them, so apologies in advance if we aren't able to get round to your question, but we will have a Q&A answer session in a little bit after the speakers have spoken. So I'll hand back to Jan now.
Thank you, Jonathan. Right, so the purpose of today's webinar is twofold. And it's firstly, like many people across our society, NPC members are genuinely concerned and fear what the government is currently planning for the NHS and our social care system. Despite their promises that a new NHS bill and the government's long-awaited social care reform will integrate and transform both services for the better, the NPC has serious concerns about what is being proposed. There are clear signs that despite their denials, the government is preparing to sell off NHS services to the private sector and to US investors. With fewer tendering checks in place, as proposed in the new bill, we ask, what is there to stop them? And shortly, we will hear from our guest speakers who understand the implications for us in all of these proposals. But first, the other purpose of today's webinar is to launch the NPC's Health and Wellbeing Manifesto, and that was recently approved by our executive committee. Now, this is an important document because it aims to uphold the rights of older people to quality and health services. And it outlines our campaign for a national care service, free at the point of need for everyone, funded by taxation and working alongside the NHS. And it repeats our demand for an independent commissioner for older people in England, with the judicial powers to uphold our rights and press for change. Now, older people are individual citizens who deserve to be valued for their contribution to society, and they still keep giving. They deserve services that enable a better quality of life, health and well-being, and we believe only a publicly accountable NHS and National Care Service can offer this. And our new manifesto sets this out in a clear and constructive way. Now, you can't see all of it on the screen, but we will be sending copies of the manifesto to the Prime Minister, all the members of his cabinet and government, along with every member of the shadow Cabinet. So we'd like your help in getting the government to implement our manifesto and ask you to download a copy of it from our website to send to your MPs, or if you're not online and people who are not online want a copy that you know of, please ask the office to send you those through. We'd be very happy to. So that is our Health and Wellbeing Manifesto for older people. Thank you, Jonathan. Right, I'd now like to introduce and welcome our first speaker today. John Bosco Obo works as a campaigns officer at We Own It, which is campaigning on NHS and public transport, among a lot of other areas. He got his start in campaigning in the mid-2010s at the University of Fort Hare in South Africa, as part of the Fees Must Fall and Decolonise the Curriculum movements. For the past 3 years, he has been a campaigner for community rights as part of ACORN, the community union. He's also studying towards a PhD in philosophy at the University of Sussex. So will you please welcome John Bosco.
Hi, thank you so much, Jan. It happened to me again. I forgot how to unmute myself. And I'm so grateful that you've invited us to this meeting to come and share in this conversation, this very important conversation. I wanted to start by saying a little bit about We Own It. Some people here may already know who we are, but just for the benefit of those who don't, We Own It is, we like to think of ourselves as the voice of public service users. And of course, our name doesn't necessarily hide our agenda. We are a voice for public service users. We run campaigns for public ownership of public services against privatization. And the rationale of the work we do is pretty simple. We use our public services, we pay for them through our taxes, local and national, and therefore we should own them. And owning them essentially means that they should be accountable to us and not to private shareholders. And of course, this extends across the range of public services, and we run campaigns around the privatization of our water, of our energy, of our transport. We recently got the mayor of Manchester to bring the buses in Manchester into public control. We run campaigns on the NHS, on probation services, on schools, on children's services, and of course on care. Yes, and among many other areas. But for this morning, or afternoon, it feels like morning. I wanted to talk briefly about two areas in particular with respect to the NHS, given the theme of this afternoon's webinar. I wanted to speak about the new reorganization of the NHS that will be brought on by the new NHS legislation that the government is trying to put through Parliament, which we believe is likely to come before Parliament sometime in July. And yeah, we want to look at how that will change the NHS and what it will mean for you and I when it comes to the care that we get from the NHS. And I also want to speak to you about not just the dangers that lay ahead, but the dangers that are already here with us in the NHS as we speak, especially with respect to our local GP surgeries and the availability of the care that we get from there and the quality of that care that we get from there. So if you followed mainstream media coverage of the white paper, you might remember that sometime in April, I believe, the white paper leaked before the government had the opportunity to put it out on their own. And during that period, the government scrambled to try and frame the debate around the white paper, which was quite strange because they usually would say things like, we don't comment on leaked papers. But the fact that they commented on it kind of gave us assurance that this is exactly what they're planning to do. But of course, they have subsequently announced those plans in the Queen's speech. So you would have seen in the press that these quote unquote reforms, and I'm going to continue to use reforms in quote because reforms often carry the connotation of something good, but these are far from that. So these reforms have been covered in the press as representing a reversal of the 2012 Health and Social Care Act. And to the extent that the Health and Social Care Act of 2012 has been kind of viewed as the cause of a lot of what's wrong with the NHS today, rightly, it has been treated as a good thing, right? Because if the Health and Social Care Act is bad and this is a reversal of it, therefore this is good. But far from that, this bill is, this bill is far from good for the NHS. So the government would like people to think so, of course, to think that they are indeed ending privatization in the NHS because they know that privatization is incredibly unpopular. According to a recent Survation poll, about 76% of voters said the NHS should be reinstated as a fully public service. Only 15% were against that statement. So the government are trying to quack like a duck, but not walk like a duck. So in this particular case, if something quacks like a duck, it is not a duck, it is probably the government. So in actual fact, the quote unquote reforms that this would bring about, that the bill would bring about, would give private companies a role in designing the nature of the care that people get in the NHS. They will be able to do so through new bodies, which are already forming across the country under different names. In some places, they call them alliances. In some places, they call them partnerships. But once the law gives them statutory effect, they will be called ICSs, Integrated Care Systems. So these will have boards with representation from local health authorities, so the current CCGs, from local councils. Actually, there is only going to be one person representing the local councils in these ICS boards, which is not at all sufficient. And although these new bodies promise integration and joined up services as they commission healthcare in any given area, the way they're going to be set up also means that private companies will be able to sit on the boards and have, and more importantly, will be able to make decisions about our healthcare. And I think that this is an irreconcilable conflict of interest. If you are, on the one hand, going to be responsible for making decisions about the healthcare that people get, and you are, on the other hand, also going to be providing that care, it's a conflict of interest in the sense that you are going to obviously make a decision that is beneficial to your bottom line, right? Especially if you're a private company whose overwhelming preoccupation is finding ways to make money, as opposed to if you were a CCG whose overwhelming objective, at least in theory, is to advance the health and well-being of the people in your area. So we know that this has already happened. In the last few weeks, Virgin have been given a seat on the new NHS decision-making body in Bath and Northeast Somerset. And we've been campaigning against this, and we will continue to campaign against this this month. So we anticipate that these new systems, the ICSs, will also open the door for more cronyism. Of course, if you allow more companies into the system, the door it kind of opened for cronyism, the kind that we have seen run rampant during this pandemic. As yet more contracts could be given to government pals like Serco and Sotel and Deloitte, as we've seen in the pandemic, and without any competition. For the government, that's what they mean when they promise to reduce bureaucracy. The bill promises to end the need to put all contracts out to tender it gives Matt Hancock or whoever the Secretary of Health is the power to just essentially hand out contracts to their mates. Yes, and we will inevitably, because we've already heard the tone that Matt Hancock is bringing to this, that talking about how we would not have the vaccine if not for the private companies when the government invested billions into the vaccine. And of course, talking about how the lesson of the pandemic is that we need to work with private companies. He's already signaling that they're going to be giving out more contracts to private companies, despite the shambles that we've seen by private companies in terms of track and trace and other services that have been given out to them during this period. So additionally, key organizations that work in this area and campaigners like ourselves and the local government association have raised concerns that there will be a reduction of accountability and democratic oversight over our NHS, especially given the fact that as of right now, we have about 135 clinical commissioning groups responsible for all of England. After these reforms are brought in, there will only be 42 integrated care systems, which means the kind of accountability framework that the NHS operates under moves further and further away from the people who are supposed to hold that system accountable. So the measures inevitably result in larger bodies, which are further removed from the needs of the people, from the concerns of the local communities that they're supposed to serve. And of course, we know that when they make a wrong decision, as of right now, we are still able to put a bit of pressure on them and get them to reverse decisions, or at the very least, explain those decisions. The further away from us these bodies move, the less likely it is that we can do that. And finally, there is an element of the new bill that gives private companies an incentive to, as they like to characterize it from their own point of view, to moderate the growth of healthcare demand. So essentially, in theory, the idea is, well, it's going to incentivize these companies to prevent people having the problems that then require them to be cared for, right? If you kind of look into preventative care for diabetes, for heart issues, for cancer, then you don't have to provide the care when subsequently. Right, so the idea is to incentivize them to invest more in preventative care, so that then if the NHS saves any money as a result of that, those companies can share in those savings. But of course, we know that in practice, this is going to lead to private companies instead deciding to just cut corners in the provision of the care, so that they can save that money, because they're going to end up benefiting from the sharing of those savings, right? So this is incredibly dangerous for the quality of care that we end up getting. Now, this is about what is going to happen when the NHS reorganization bill, if it passes. Hopefully it doesn't. We're going to fight it tooth and nail as it passes through the House of Commons and the House of Lords. The Shadow Health team has already indicated that they're likely to oppose it. At least they're likely to oppose certain important aspects of it. And we have important allies in the House of Lords who are able to give the government quite heavy defeats on elements of the bill as well. So we're going to be fighting as hard as possible on this. But there are already dangers in the NHS that exist in it right now, that we can do something about right now. So in terms of dangers to our local GP practices, you may already have heard about a company called Centene that recently took over another company founded by 6 GPs some time ago. That company is called AT Medics. AT Medics ran 49 GP practices across England until February this year, when they were taken over by Centene. Centene is a huge multinational American health insurance company. And Centene, of course, already ran 21 surgeries across the rest of England, because they already they had majority share in another GP company called the Practice Group. So which means they're now run upwards of 70 GP practices across England, which gives them control over the healthcare, the primary care of over 500,000 people in England. The CCGs in London, where the 49 practices are located, approved the takeover of those practices by Centene. And there is now a judicial review being launched to probe that decision, the legality of that decision by the CCGs. We are very doubtful that that decision was legal. And of course, we will hear from authorities about that. I wanted to kind of capture quickly some of the very important elements of the takeover of GP practices by Centene, but also more broadly by companies like Centene. And one of the issues that we always come up against, and I imagine that some people in the audience today are already thinking of it. The question is, aren't GP practices private already? And this is just private company being taken over by another private company. We have a detailed article on our website that answers this question quite comprehensively. Our website is weownit.org.uk. But of course, I can kind of give you the crux of this issue. A company like Centene, a huge multinational corporation, is legally different, even in the eyes of the NHS, in the eyes of the law, from a traditional GP practice that runs GP surgeries in the UK, in England. So there are three kinds of contracts that companies can get. There are GMS contracts, general medical services contracts, PMS contracts, personal medical services contracts, and APMS contracts, alternative provider medical services contracts. The first two contracts can only be gotten by traditional GP partnership or an individual GP practicing on their own. And APMS contracts were only introduced in 2004. So up till 2004, private companies could not get contracts to run GP partnerships. So the law itself sees those two kinds of companies as different. APMS contracts were introduced in 2004, and it was APMS contracts that allowed a company like Centene to be able to run GP practices. Essentially, the only person that is not allowed to run a GP practice under an APMS contract is somebody who has been found guilty of killing somebody. But you could pretty much, you and I, Jan and I, could pretty much just create a GP company without, I don't have medical training. I don't know about Jan. I suspect that she probably does. But if she does, then she doesn't count. Two of me who doesn't have training could found a company and get an APMS contract if I write a flashy enough approval process. And that is the doorway. A healthcare lawyer here in the UK recently called APMS contracts the doorway into the NHS for private companies. And that's how they're getting into the NHS now. So in reality, even if technically GPs are independent contractors, the law itself recognizes the important difference between the two kinds of companies. Yeah, of course, but there is also substantive difference between the care people get at a GP surgery run by traditional GP partnerships and the care that they would get at GP partnerships run by company like Centene. There is clear evidence that patients are worse off when GP practices are run by private firms instead of traditional GP partnerships, according to a 2015 study published in the Journal of the Royal Society of Medicine. They found that in 15 out of the 17 metrics that they used to compare the two kinds of practices, partnerships run by traditional GP partnerships had patients much better off than those run by private companies. And in terms of Centene's track record, of course, we know that Centene took over a GP practice in Harlow, Essex in 2018. And after a brief period, they discovered that they couldn't make a lot of profit from it. They decided to abandon it, and the CCG ended up closing that practice to much anger from the community. They did the same, of course, in Leicester and Camden, under the practice group, as I mentioned earlier. But very importantly, closing GP practices that are not profitable from their point of view is a part of their strategy. If you look at their 2019 annual company paper, they do actually say the strategic exit of certain loss-making elements of our business has allowed the group to consolidate its contract base without compromising profitability. Rationalization of our business activities has been a key feature of our strategy throughout 2019 and has continued into 2020 as the business seeks to divest of activities that have not met profitability targets. And they go on themselves to list the contracts and GP partnerships or GP practices that they have abandoned. Just to go a little bit further in terms of their track record, in the US, Centene has been sued by hundreds of people who they sold health insurance to, and continued to take their money, but did not provide health centers and doctors to look after the needs of those people. They were also found guilty in a court in the state of Arkansas of systematically underpaying medical doctors. Where I come from, we call that wage theft. So they essentially stole the wages of doctors. And in December 2017, they were fined $1.5 million by the state of Washington for pretty much the same thing that they are currently being sued for: selling health insurance to people, but not providing doctors or health centers. That tells us something about the character of this company. In March this year, they were sued by the state of Ohio. They were accused of corporate greed because they essentially double billed the state for services they provided. And they did the same thing in the state of Mississippi as well. And last week, they actually settled with the two states. They paid the state of Ohio $88 million, and they paid the state of Mississippi $55 million. Of course, they did not admit any guilt, but if you are going to give two states $153 million, you probably did something wrong. But I'm not saying they did anything wrong, but I will leave you to decide for yourself what you think they did. Now, the reason for the likely loss of services from a company like Centene or Virgin or any other profit greedy company running our services is quite obvious. Taking profits out of the system will invariably have an effect on the quality of care that people receive. This could come in the form of a move away from personal care to care provided online. It could also come in the form of cuts to employee numbers. We are already seeing a move toward cutting the number of doctors who are in GP partnerships and increasing the number of I've forgotten exactly what they call it, associates, people without medical degrees standing in for doctors, or people without nursing degrees standing in for nurses. We're already seeing a move toward that, and we know that that's absolutely going to affect the care that people get. Those people cannot prescribe medication. They cannot really tell you authoritatively what's wrong with you in a way that a doctor can. Yes, and of course, we know that Centene, being a profit-greedy company, will definitely find these ways of maximizing profit. And one important thing to keep in mind as well is that the chief executive of Operos is Centene's company here in the UK, recently went to work for Boris Johnson at Number 10 as a special advisor on health. And she was the pioneer of what was called new models of care. And that is essentially the model of care that pioneered the idea of cutting medical doctors out of GP partnership, out of GP practices. And that danger is likely to only continue to grow over time. And lastly, I wanted to kind of highlight the potential risk of losing the founding principle of the NHS. We always speak about the idea of the NHS as kind of being founded on the principle that money should not be a hindrance to you and I being able to gain access to the healthcare that we need. And we often treat that as only meaning that, or the government often speaks about that as only meaning that the care we get should be free at the point of need. That is true, but that's not the only thing it means. It also means that profit should not stand in the way of our ability to get care. So if a company is unable to make profit from providing the care we need, we should still be able to get that care. But the framework that this operates on is this company comes in, takes over your local GP practice, it runs it for 6 months, it finds out it can't make the profit it thought it can make from this practice. On this framework, it is allowed for them to just cut and run, leading to your GP practice closing down. That means you are being deprived the care you need because a company cannot profit from providing that care. And imagine that principle being extended to ambulance care. Imagine that principle being extended to cancer treatment. Imagine that principle being extended across the range of services the NHS provides. And that principle is at risk of being wholesale adopted into the NHS if companies like Centene are allowed to continue to roam unhindered in our NHS. And I would invite you to join the fight today against a company like Centene running our services. And thank you so much for having us. And I'm very excited to hear your thoughts and questions at the end of this. Thank you.
Thank you, John Bosco. We have some questions, but if Sir Michael is here, Bev, we'll carry on with Sir Michael, and we'll round up maybe at a later date. There's quite a lot of questions, John, so be prepared. Okay. All right. Now, I am extremely honoured to welcome our next speaker, who is Sir Michael Marmot, who's Professor of Epidemiology at the University College of London. Now, Professor Marmot has led research groups on health inequalities for nearly 50 years. He's the advisor to the World Health Organization, Director General on social determinants of health, and in the new World Health Organization Division of Healthier Populations. He's also the recipient of the World Health Organization Global Hero Award. And Sir Michael is the author of books, The Health Gap, The Challenge of an Unequal World, and also Status Syndrome, How Your Place on the Social Gradient Directly Affects Your Health. Now, from 2014 to 2017, he held the Harvard Loan Professorship and has accepted honorary doctorates from 18 universities. He has chaired several important global health and care commissions for the World Health Organization. At the request of the British government, he conducted the Strategic Review of Health Inequalities in England, which published its report, Fair Society, Healthy Lives, in 2010. And his latest report in 2020 was the much lauded Health Equity in England, Marmot Review, 10 Years On, and Build Back Fairer, the COVID-19. So will you please welcome Professor Sir Michael Marmot.
Thank you, and it's a pleasure to be here. I listened in to the previous presentation, and he talked knowledgeably and eloquently about the new integrated care systems. I'm not going to talk about healthcare at all. I'm going to talk about health. The state of Britain's health is terrible, disappointing, not where it should be. Before the pandemic, in my 10 years on, the Marmot Review 10 years on, we documented that an improvement in life expectancy that had gone on for a century of about 1 year every 4 years for men and women, in 2010 slowed and nearly ground to a halt. If as a government, you said, we've got the aim to slow down the improvement in health, you would look at the figures and say, by golly, we're powerful. We did it. We got elected. We had the policy to stop health improving, and we achieved it. Now, I'm not suggesting for one moment that that was the policy of the government elected in 2010. But if it were, they did a very good job. And then the question is what happened a result of government policy, even if it wasn't the desired aim of government policy? Now, we don't have a controlled experiment to answer that question, but in a way, my 10 years on review was looking back at this picture and asking what happened and why. The second feature of health in February 2020 was that inequalities had increased. I've been demonstrating my first paper on the topic, given that you betrayed my age by saying how long I've been doing research on this issue, so I can't hide. So my first paper on the social gradient was in 1978. God, that's a long time ago. And what it showed was that it's not simply that health inequalities are confined to poor health for the poor and reasonable health for everybody else, but it's a social gradient. The poorer people are, the shorter their life expectancy and the worse their health. And what we showed in our 2020 report is if you classify people by level of deprivation of where they live, you see the gradient, and the gradient got steeper over the 10 years. And there was an interaction with region. Really interesting. We know that in general, mortality is higher in the Northeast and the Northwest and the Midlands than it is in London and the Southeast. But you need to look at level of deprivation. It's actually not much higher if you're in the least deprived 10%. If you're rich, it doesn't much matter where in the country you live. Then the more deprived the area, the bigger the disadvantage of being in the north compared with being in the southeast or London. Or putting it a different way, when we look at the gradient by level of deprivation in life expectancy, it's steeper in the northeast and the northwest than it is in London and the southeast. And what we saw, particularly for women, is for women in the least deprived 10%, life expectancy went up a bit in every region of the country. But for women in the most deprived 10%, life expectancy went up in London and went down in virtually every region outside London. So, just to summarize again, we know poverty is bad for health. That's not new. But the social gradient, it's not just people who are in dire poverty, but people in the middle have worse health than those at the top and better health than those below them. And that social gradient got steeper, number two. And number three, health for the poorest people got worse outside London. That's a terrible state of affairs. Now, you're in your title, pensioners. This affected the older stages. So it wasn't that older people were immune from this. It affected the older stages. And this is a terrible state of affairs. We've come to expect, reasonably enough, that health gets better all the time. When today's pensioners had their children, they expected their children would have better survival than when they themselves were children. And they were right to expect that. That's what had been going on all the time. And when today's pensioners were 40-year-olds, they could expect better life expectancy than when their parents were 40-year-olds or 60-year-olds. That's right, kept improving all the time. And in 2010, that stopped improving pretty well. And the inequalities got bigger. And health for the poorest people went down. And it's not just length of life. When we look at disability-free life expectancy, the social gradient is steeper. It means that people at the top were living about 12 years of their lives with disability. And people at the bottom, in the most deprived areas, were living about 20 years of their lives with disability, of their shorter lives with disability. And the level of ill health went up. So life expectancy more or less stopped improving, but the level of ill health actually went up. This is where we were pre-pandemic. Why? Well, as I said, it's not a controlled experiment. So to say why this happened is not straightforward. The government was a bit sensitive. Surely you're not saying it's anything we did in 2010 that could have led to this, could it? Maybe we've just reached peak life expectancy. Well, the improvement in life expectancy, the slowdown in the UK was more marked than in any other rich country except Iceland and the United States, the slowdown between 2010 and 2019. So no, we had not reached peak life expectancy. We're doing something badly here that apart from Iceland, the only big country that was doing worse was the United States. And in the US, life expectancy went down 3 years in a row. This is all pre-pandemic. The government elected in 2010 had as an ambition to roll back the state. And they did. In 2010, 2009-10, of total GDP, 42% went on public sector expenditure. And that 42% over the decade went down to 35%. And if you look at spending by local government per person, the poorer the area, the bigger the reduction in spending. Thinking about older people, look at spending in adult social care. In the least deprived 20% of areas, the spending on adult social care went down by about 3%. And then the more deprived the area, the bigger the reduction. So in the most deprived 20%, it went down by about 15%. What's going on? The greater the deprivation, the greater the need. The greater the need, the greater the reduction in spending. Does this provide a potential explanation for the miserable health picture that we saw? Well, it could. Then came the pandemic. And you know all too well what happened. At the beginning, they said, maybe it's a great leveler. The Prime Minister got sick, the Prince of Wales, Tom Hanks, the actor. maybe it's the great leveler. No, never. Pandemics reveal, expose the underlying inequalities in society and amplify them. And that's what this pandemic did. And we saw the social gradient in mortality from COVID-19, and we saw the high mortality in different ethnic groups, Black African, Black Caribbean, Bangladeshi, Pakistani, and to a lesser extent, Indian. Much of the excess in these four ethnic groups, Black African, Black Caribbean, Bangladeshi, and Pakistani, much of the excess statistically could be attributed to deprivation, geography, where people live, other socioeconomic characteristics, and among Bangladeshi and Pakistani to prior ill health. And my approach in seeing those figures is that we have to deal with structural racism. This is not simply a matter of whether people wear masks or wash their hands. And structural racism can work, putting it crudely, in two different ways. One is that people are exposed to socioeconomic disadvantage, which is why controlling for socioeconomic disadvantage explain more than half of the excess. But there are other ways that are not captured by these conventional socioeconomic measures. The experience, the everyday experience of racism can impact on people's health. And so my second report in 2020, published in December. So I waited 10 years to do the Marmot Review 10 years on. I waited only 10 months to do the COVID-19 Marmot Review. And we called it Build Back Fairer. It is, one would hope, an opportunity to do things differently. I would argue we do not want to go back to the status quo of where we were before the pandemic crashed upon us in February 2020. I've already said that we had a miserable state of health, very disappointing. We want to create a fairer society at every age group. My 2010 review had 6 domains of recommendations: give every child the best start in life, education and lifelong learning, employment and working conditions. Number 4, having enough money to lead a healthy life. Number 5, healthy and sustainable places in which to live and work. And number 6, taking a social determinants approach to prevention. I think all of those are needed. But when I ask myself the question, why pre-pandemic we had more or less the slowest improvement of any rich country except the US, and during the pandemic, certainly in the first year, we had the highest excess mortality. Why did we manage the pandemic so badly? And why was our health so poor coming into it? What's the link? And I think the link could potentially work at 4 levels. First, poor governance and political culture. Second, increasing social and economic inequalities. Third, the disinvestment in public services. And fourth, we weren't very healthy coming into the pandemic. Building Back Fairer, I would argue, needs to address all 4 of those: the quality of governance and political culture, the social and economic inequalities, the disinvestment from public services, and the fact that we weren't very healthy. we need to take action on my 6 domains that I laid out a moment ago, but we need to be thinking about this meta level and thinking about the tragedy that happened in care homes during the pandemic. We need to put equity of health and well-being at the heart of all government policy. Thank you.
Thank you, Sir Michael. I am always amazed how far down we've gone over a number of years. And you're so right in terms of the disinvestment in public services. And if there was ever proof that public services were really needed, it's been the pandemic, I think. Would you be able to take some questions or
Sure.
some comments? Thank you so
Sure.
much. We're looking at, in terms of the principle of preventative care, yeah? And John says, the principle of preventative care is a good idea if it's delivered through public health care. For example, primary, second, and tertiary care. And for older people, it could eventually reduce comorbidities and an extended period of healthy living. How do we get back to supporting preventative care, Sir Michael?
Well, I think of preventative care in 2 ways. One is what doctors or other health professionals, nurses, do with individual patients. But second, I think of it along the lines that I've been discussing, taking action on the social determinants of health. The opening line from my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. So preventive care is laudable, but we also have to address the conditions that make people sick. And that's not simply done by what one health professional does with one patient. It relates to policy at national government, at regional, local government, improving the conditions, as we said in the Global Commission, improving the conditions in which people are born, grow, live, work, and age. And so a lot of people have commented, including me, on the disinvestment from public health that happened when Public Health England was established in 2012, and public health was moved from the NHS into local government. And I thought both moves were good moves, potentially, but Public Health England's budget was cut by 40%, and £800 million was taken away from local public health. Well, that's not good. That's not good. So even though what I'm talking about is much broader than organized public health, but that kind of disinvestment is in a way saying that we're not interested in prevention, in public health, we're whatever. Now, I think people thinking about the NHS are increasingly turning to thinking about prevention for very good reasons. And what John Bosco was saying, notwithstanding, I think we ought to be trying to work with the new configuration of care and integrated care to try and push it in the direction of social determinants of health and prevention.
Right, thank you. I have another one here, and this goes back to the days of Tony Blair. This is from Mary. She said, I would like to ask a question about the role of Tony Blair in introducing 11 private healthcare providers into the NHS family in 2006. At that time, he wanted the private sector to provide up to 40% of operations and would drive up quality of services to patients. I mean, do you think that that actually happens, Sir Michael?
Well, as I said at the beginning, I don't want to talk about healthcare services, not because they're unimportant, but that isn't primarily where I spend my 7 days a week.
Okay, that's fine. Thank you. I've got a question for John Bosco. When I find it, John. Right. It's from Alex. Now, this is a bit of a challenge for you, John Bosco. John Bosco incorrectly stated that the Shadow Health team has said it will oppose the Health and Care Bill. In truth, Hancock described Jonathan Ashworth's position on the NHS White Paper in the House of Commons as qualified support. Would you like to comment on that, please?
No, I think that's a really useful observation. I would say, though, that my statement was not based on the exchanges in Parliament, which I often find a little bit sickening. We have had private meetings with Ashworth and his primary care minister, Alex Norris. And he has specifically indicated that they will be opposing the elements of the bill that allow private companies to sit on board. So that's what I based my statement on. Obviously, they do like to put on a bit of a show in Parliament, and it often leads to trivializing very, very important issues. And Matt Hancock probably knows a little bit more than I do, but from what John Ashworth told us in a meeting with him, the Labour Party will be opposing the private companies sitting on boards.
Thank you, John Bosco. Right, there's another one for you, Sir Michael, about public health. Talks about we need the vast investment in public health, and prevention was always part of those aims and objectives. How can local services progress in view of the funding mechanism? I mean, clearly this is about Public Health England now being moved to a centralised function, I believe. So it is really crucial to local public services run by local councils. So is there an answer to that, Sir Michael?
Well, I don't think money is everything, but it's not nothing. So if when public health was moved into local government and the public health budget was cut, but local government couldn't make up any of the difference because their budgets were being cut. And the more deprived the area, the greater the cuts. I remember somewhere in the mid 2000, about 2015 or that sort of time, sitting in Newcastle with the chief executive of local government, and he said, we're just about at the level where all we can deliver is statutory services. We're cut to the bone. We've got no discretion at all. Never mind parks and libraries and children's play areas and the like. We'd like to be in the business of creating better, healthier, happier populations. And we're not. We'd be just slashed. We can't do any of that. Now, I think local government has tried to do the best it can with the hand with which it's been dealt. But it's a very difficult hand. So money isn't everything, but it's not nothing. And it needs to be funded. I mean, I said at the end of my Build Back Fairer report, I quoted from report card 16 from UNICEF 2020 that looked at child well-being. Out of 38 OECD countries, rich countries, one being the best, 38 being the bottom, we rank 27th. The US ranks 36 out of 38. And I said at the end of my Build Back Fair report, my recommendations will entail spending money. And if you say, where's the money going to come from? Just ask yourself the question, is a ranking of child well-being of 27th out of 38, is that just something you accept? You say, no, we're not going to do anything to improve that. We'd rather roll back the state. Our level of taxation in Britain went from around 42%, which was the middle of the European range, to 35%, which is near the bottom of the European range. In the US, it's 25%. So we can, as people have said, do we want Nordic level of services with US level of taxation? Well, it doesn't work. If you want Nordic level of services, you've got to have Nordic level of taxation. And if you say, well, we don't want that, fine. Then our children well-being can go down from 27 to 36 out of 38. So you've got to make these important decisions. What's important in the polity? That's why I talk about the governance and political culture. Do we prioritize children's well-being? Do we want our children to grow up with damaged self-esteem, damaged psychological well-being, less good physical skills? Are we happy with that as a future? If we're not, then we've got to do what's necessary. And at the other end of life, the NPC is concerned about, we know the quality of life for older people is very much affected by social policies. And we've got to decide, is that important? Well, if we're a rich country, I would say it is important. And I noticed, I glanced at the chat, somebody asked, have we got the right economic model? Last week, I was speaking, and I had my iPad next to me, and it flashed up on the screen. I get these news flashes. It says, Jeff Bezos, the chief executive of Amazon, Jeff Bezos is going to shoot himself. I thought, what? Well, better him than somebody else. And then I looked at the flash again. Jeff Bezos is going to shoot himself into space. Well, so there was that news item. Then there was another news item in the New York Times. I think it was ProPublica got hold of the tax returns of Jeff Bezos and Warren Buffett and Elon Musk and one or two others. In the 5 years, 2014 to 2018 inclusive, Jeff Bezos's personal wealth went up by $99 billion. The poor chap, he didn't make his century. He got into the nervous 90s and then conked out. $99 billion in 5 years. And given that these rich people, what they take in income is neither here nor there, it's purely arbitrary. So what this website did was they calculated the rate of tax he paid on his wealth accumulation as well as income. And the rate of tax was 0.9%, less than 1%. The average American family on an income of $60,000 pays about 14% totally in tax. Jeff Bezos paid 0.9%. Anything wrong with that economic model? Well, a little bit. I was on a panel last week with Nigel Wilson, who's the chief executive of Legal & General, and we're going to do some work with them. And he said, we want an inclusive capitalism, not an exclusive capitalism. And he said, the UK pensions industry has £6 trillion. There's money sloshing about, he said. The question is, can we put this to good use to improve health and reduce health inequalities? Wow, So I'm not saying toss out capitalism, but let's have an inclusive capitalism. And there's something terribly wrong when Americans are starving. Child poverty is up at the 30% mark. There's food poverty. And last year, during the pandemic, between March and December, Americans, the US's 651 billionaires, increased their wealth by $1 trillion. That's 1,000 billion. During the pandemic, they could write a check of $3,000 for every single one of the 330 million Americans and have the same wealth they had at the beginning of the pandemic.
Mm.
Is there something wrong with our economic model? I think it needs a bit of correction. I think it's going off course. And so we shouldn't ask, is there enough money sloshing about? There's plenty of money sloshing about. Let's put a priority on improving child well-being and improving the quality of life for older people and reducing inequities. And we can do it. We've got the knowledge, we've got the resources, we've got the people. We've got to just put it as a priority.
Yeah, thank you, Sir Michael. I mean, you're absolutely right. And it's mainly our money that's sloshing about, isn't it? So it's time to redistribute it where it's needed. So thank you for your contribution. I'm going to move on now and introduce to you our final guest, who is Tracy Jarrett, who manages the Lewisham Pensioners Forum. Now, Tracy is a community development worker and a qualified trainer with 3 decades of experience working in the statutory and voluntary sector. She's been manager for Lewisham Pensioners Forum since 2017. Now, that's a charitable organisation campaigning for the voice of elderly living, working and visiting the borough of Lewisham in South East London. She's passionate about addressing and challenging inequalities, and Tracy has specialist knowledge in mental health, race awareness, gender inequality, and organic health and wellbeing lifestyle. And if that's not enough, she also has a radio programme and is a podcaster. So welcome, Tracy.
Welcome, greetings everyone. I'm assuming that you can all hear me correctly. I'm just going to try and screen share. But in the meantime, while I work that out, I just want to say thank you to the last 2 speakers. Absolutely educational and profound. And thank you, Professor. I don't know if you're gone or he's had to leave. Thank you for those stats, and it's clear that money is sloshing around. Just bear with me. I need to just, can you see my screeners, yeah? No?
No, Jonathan needs a screen share.
Let me just see if I can find. Can you see that now?
No, we can't see anything, Tracy.
Hang on a minute. I've got the ability to screen share, haven't I? How's that?
There you go. Yeah.
Excellent. All right then. So this is the Lewisham Pensions Forum. I'm just going to be talking about the impact that the pandemic and the lockdown, and to me it feels like 2 separate things, although they're linked. And I'm going to be talking about the work that we're doing in Lewisham and how pensioners, who are our cohort, is managing and responding to the changes that has come about in most recent times. So, let's see, Is it moving? Right, excellent. So our work is primarily to support older people that work, live and visit Lewisham. And our job is very much about ensuring those that have retired, because we have people that are retiring early, but people primarily from 55 upwards. We want to ensure that their voice and their views are heard. We also want to shape and campaign about key issues that matter to us. We've done a lot of work with Jan in the past around a number of subject matters, and we're always willing to get involved and make a difference for the better for older adults. We like to comment on national and local policies and basically think about the practicality of what the government or national or local authorities might be thinking. We were set up in 1986. We're a registered charitable organisation since 2014, and we have 400 members and some who pay a membership fees. As you can imagine, as a result of the lockdown, our normal membership day hasn't happened. Everything has had to be done differently. And we mail out to 100 networking organisations that we work with. And we have about 1,500 newsletters that we mail out to our members and networks. We received main grant funding, and we also received recently Bright Ideas money for IT and website development. We also received COVID response funding that allowed us to do outreach to our members and also provide more regular newsletters. We received donations through our membership and donations per se. Like I said, these are just some of our core objectives. I don't need to go into any of that, but basically, this is how we go about doing what we do. So we are very proactive in working with other organisations who have similar values and work with similar cohorts as we do. Okay, now how do we do this? We do this through our forum meeting. I'm sorry, it seems like I'm rushing through this, but I just want to give you a sense of who LPF is. We're located in Lewisham and how we go about doing what we do. So we have regular forum meetings. We have our Pensioners' Day, which is held once a year, generally during October. We have our regular Monday project, which is held every single week on a Monday. And we have social outings, which is basically virtually every month or every 2 months. And we have our bi-monthly newsletter. And these are the mechanisms in which we interact and communicate with our community. So this is how we do our thing. Obviously, since since the lockdown, everything came to a stop. Absolutely unbelievable. Since then, what we've done in order to respond to the pandemic and the lockdown, our normal Pensioners' Day was rolled out over 3 days, and it was online. Everything had to go online. Our newsletter moved from being a bi-monthly to being a monthly, and moved from being black and white to being coloured. We also started doing outreach, phoning our members, phoning those that were that had been brought to our attention. Because we don't just exclusively work with those that are members, we also work with those who have been signposted to us who may not be members as yet. So we don't exclude anyone. So with that, we've been doing, in terms of the outreach, we've been ringing people, finding out how they are, talking to people. In terms of our personal outreach to people, we've had volunteers who've been delivering food packages to our members, and delivering the essentials like masks and sanitizers, and finding out basically how they're doing. We have our regular forum meetings, which I told you about, which is every 2 months, but since the lockdown, that's been pushed online. And just to let you know, we've been working collaboratively with public health, especially raising awareness around the vaccines, food banks, and where to get those services. And also, we've had to have our AGM online, as many other charity organisations had to do. In the midst of all of that, we've also moved offices this year. So we're in this new office on the 5th floor of the Lawrence House. And what we've also been doing to measure the impact or get a sense of how people are feeling, we've been sending out surveys and questionnaires and phoning up our members. And a couple of the surveys that we done, one of them was around the impact of COVID-19 stroke pandemic lockdown on your mental health and well-being. And we did some work around digital confidence survey. And that was in partnership with our local authority. And we got events organised for August, I mean. So I've heard a lot about what's been said, and it's very different on the grassroots. And many of our members have raised real concerns about their mental well-being, about accessing services online, their GP, all sorts. And it's been real sad. It's been very sad hearing some of these accounts and stories. These are just some quotes from our surveys. I didn't do too bad last year, but as the person goes on to say, they feel like they're in a prison. They're feeling very depressed, very low moods, you know. We've had others that have expressed major concerns about their physical well-being because of the lockdown, not getting regular exercise, they're being shaky on their foot. Some of them, some of our members have had falls in the home because they're not getting the exercise that they would get. We've had others that have been angry and depressed, shaking, confused. We've had others that have talked about loneliness, depression, some that are caring for loved ones that have got mental health issues, saying that their loved ones have become very violent, very aggressive, not being able to understand why they can't go out, not wanting to wear masks. Others have been supported by their community, in terms of getting shopping for them. Others have learned new neighbours by actually chatting to them over the fence. You know, others are very sad that they've not seen their loved ones for nearly a year. And as you can see by some of the comments, many are worried about going to a crowded situation again. And that is a massive concern because although things have been put a halt on it, today was the day that everything would have been lifted. We've had to push forward some of our plans or push back because we had hoped to start running our Monday project again. And what I'm hearing is that people are scared to go into big crowds again. They're very reluctant. However, they recognize that they need to get out soon because their mental well-being is taking a turn for the worse. And they're experiencing long bouts of depression. It isn't getting any easier. We also heard from those that are saying that they're becoming, or their community appears becoming more cynical, you know, more down, you know, feeling very negative about the future. We've also heard of those that are really struggling to get access to GP services. Many of our cohorts, and this is something that we're not unfamiliar with, do not do online. They don't have access to broadband. They don't use the internet in that respect. So now that we've seen a lot of the GPs now moving their services online, they're finding that when they do phone, they're having to go through a whole range of names and numbers that they have to press before they can actually speak to a human being. This is causing our members a lot of put it this way, they don't trust the internet as it is. And many of our cohorts are feeling very excluded because they're not able to see their GP as easily as before. Not only that, many of them are scared to go into the GP services just in case they catch COVID. Many of those that have been vaccinated are waiting an extremely long time before they get the second vaccine. And they've been ringing our offices saying, will the second one work? Now they're ringing our office. That's because they can't get through to their GP services. We're finding people ringing us up for very practical things that the council should be dealing with. But the council, trying to get through on the council's number, it's been really difficult for many of our members. And I say all of that in order to sort of say, Lucian Pensions Forum has been around for a little while. And our biggest concern right now is that our members are feeling cut off from mainstream. We've had banks in our local area, just in this vicinity, we've had a couple of banks that have closed down. We're finding that many of our members that would access the banking services are now being told to go online because of the long queues outside post office. Our members do not have the physical capacity to stand for those long periods of time in order to go into the post office. They're extremely worried about their mortgage or their rent or their utilities bill being paid on time. This is causing our members so much stress. It's very upsetting, not to mention the number of people that have died. One of our members said, you know, that they've invested a lot of money in the NHS through their taxes, and they cannot believe that they're being treated in this way. They feel like the government has failed them as a result of how they responded to the pandemic, especially to those that are receiving care service and that are in healthcare services. You know, I'm just going to read this one, absolutely essential. That was one of the questions that we asked around the priority and the role of the voluntary sector, because like I said before, we are a voluntary sector organisation. And his response was, it's absolutely essential as the national government is not interested and the local authorities are deliberately underfunded. The voluntary sector needs to continue to represent the elderly needs so that they are not dropped off the government's agenda. It is the elderly who have worked to mainly create the wealth of the country as it is today and deserve services to meet their needs. And I think for me, that speaks volumes. We've had lots of responses to our questionnaires. And for me, this is one of the key ones because our people are not happy about how they have been treated. At the present moment, as you can see this presentation here, this just shows you the newsletters that we've been putting out. And every single month, the newsletters that we're putting out, we're getting more and more people requesting because they're not going online as people expect. Although we launched our access to broadband services on the 8th of March with the local authority, a massive amount of our cohort still requires in paper, hard copies of our newsletters. They refuse to go online. Many of them cannot afford the broadband, you know, so, and just because you're not online shouldn't mean that you should be excluded. As you can see, there are topics that we've been dealing with, and our next event is going to be held on Wednesday, which is looking at scams. Now, I cannot begin to tell you the amount of our members who have been scammed and who have potentially stopped themselves from being scammed just through talking to somebody, getting advice, you know, seeking alternative information. And I don't feel that our government has caught up with the ability of our scammers to fool people into thinking that they are providing services, when in actual fact they're scamming people out of their money, out of their personal data. This is a massive concern for our members. So one of the things that I wanted to kind of leave with you in my closing remarks, the purpose of my presentation was to say to you, we're one of the leading organisations in Lewisham. We're not the only organisation in Lewisham providing services for the elderly. But what I will say to you is that our members are articulating their concerns about what's happening to the NHS and the privatisation of the NHS services. And we're keen to support the NPC in their campaign to address these inequalities. Our members are phoning, only today I had a member phoning us saying that they want to get involved in the campaign to keep our services, our NHS, for the use of the public. And we will continue to work hard to campaign. I know our biggest job right now is trying to persuade our members that it's safe to leave their homes. As soon as we get a good date, we will be opening up the Monday project. But just because they're older adults don't mean they don't care about their community. And it doesn't mean that they're not interested in and not wanting to get involved. They are very active, they are very involved, they are very concerned, and most importantly, they should be valued and respected, and their voices should be heard. And that's what LPF, Lewisham Pensioners Forum, is about. Our voices, our older people's voices being heard. And if you want to get involved in what we are doing, that's our address, that's our email. And we do have a website, which we are updating as I speak, but please feel free to get involved. The chairman for our organisation is Bridget Sam Bailey, and we're always available. At the present moment, our office, as you can imagine, we are working from home as well as working in the office, and we're having to be very flexible. Okay, those are my final words, Jan.
Thank you, Tracy. That is a huge example of the wealth of work that voluntary organisations like the LPF do. And they are across the country. And anyone who is watching this and perhaps knows an older person, a neighbour, even some of them then the family, a friend, if they feel that they can give them some assistance and find them a voluntary project like the LPF that will help them, take them through what the issues are, and certainly give an awful lot back. So thank you, Tracy. And I want to kind of come back to what Sir Michael said in part of his speech around racism, yes, in terms of his report, the 2020 report. Do you think that it was more prevalent during the pandemic than we've seen before.
Oh, most definitely. Oh, most definitely. One of the things that we found out was that in terms, was that question for me?
Yeah,
Sorry.
yeah.
Oh, good. I jumped right in there.
No, that was a question for you.
One of the things that we found in particular in terms of people accessing appropriate services, and there's a lot of reasons. I do a radio show, and I hear from the community. It's a community talk show, and I invite a lot of our older cohort to listen in. And there were some major issues that happened in March, April, May of last year. And one of the things that I found out, somebody phoned me on the radio, live on the air, and said to me, Black people are immune to the virus. And I said to them, where did you get that propaganda rubbish from? Because viruses don't know any color. Virus is a virus. But I felt that this propaganda was deliberately sent out into the community so that Black people who are working at the forefront, your doctors and nurses, would relax about the idea of not having any PPIs. And they were drawn into a false sense of security. That was deliberate. There is nobody who can tell me that wasn't deliberate. That was some misinformation. During that time, we were seeing countries like Italy, all over the globe, with PPE equipments and addressing in the hospitals and what have you. We didn't see none of that in March and April in the UK. It wasn't until after we got our up-to-date, appropriate PPE equipment did we start to see more people. In the meantime, Black people had already been working with your flimsy little aprons and masks. Is it any wonder 2-3 months later, you see an overrepresentation of Black people dying from COVID? Now, you know, the professor did mention there were socio-economic reasons and environmental reasons. So, for example, the number of people that Black people may have in their family living under one roof may be a contributing factor. The fact that people having to work more than 1 or 2 jobs and work in lower paid jobs, and therefore don't have the luxury of saying, well, I think I've got a bit of a cough, I need to go and self-isolate for 10 days. What we have to understand, in Britain, we have a culture that normally when you become unwell, you go to work anyway. That has always been the culture. It's been flipped on its head now because of COVID. As soon as you got a little cough, or you think, oh my gosh, I could have COVID, I need to get tested and I need to go home. So in my view, it has been, I think it's, in my respect, some racist agenda. However, since then, what I'm feeling is that now that we're all sort of on the same level playing field, and I think the rolling out of the vaccine has done that, I'm most concerned about those that don't wish to have the vaccine for whatever reason. It could be for cultural purposes. And what I'm seeing is vaccine hesitancy has been a massive discourse around that. But I feel like people are being victimized. I think people are being scared into taking it. You know, I had one of our cohorts who's 85, and she wanted to take the vaccine, but she felt that she hadn't been given enough information. She had underlying health issues. She's a diabetic, and she had some heart issues. And no one had told her whether the vaccine would have side effects or undermined the medication that she's actually already taken. And my answer to her was, contact your GP. She had contacted her GP. The GP had asked her to come in She'd been self-isolating since March. This was February this year when I was having this conversation with her. And she didn't want to leave her home because she was scared that if she left and went to the GP surgery, she could catch COVID-19. These are massive issues. So I said to her doctor would be more than happy to ensure that someone contacts you and have a conversation with you about the side effects, potential side effects, and whether the medications that you're already taking could have an impact. She was met with a lot of hostility. She felt bullied. Now, we've got lots of members of who feel that way. And in some respects, I've had to contact people to alleviate people's concerns, signpost people to the appropriate services, and a lot of our members, we have people who are Black, white, from different cultural backgrounds. And I feel that many of those that are Black who have had major concerns has also felt that they feel a bit bullied, they feel victimized, they feel like their questions are not being answered. Since then, things have changed. Responses to that part of the community has become better. The government has gotten better in responding to those concerns. But I do think, to answer your question, it has been racism, and I'm just going to call it as it is.
Well, thank you, Tracy. That was really honest, and I thank you for that. I have another question for John Bosco. John Bosco, can we go back to the Bath, Somerset and Virgin Care stuff? I was saying to you just before we started the webinar, I've just sent back to Pascal, who is one of the workers in We Own It, my agreement to sign a letter around Virgin Care and the way that private companies are settling themselves in. Would you like to explain to people listening exactly why that letter's needed?
Yes, so there is at the moment not a great deal of agreement across the range of organizations that campaign against different kinds of changes being brought to the NHS. But the one aspect of it that everyone can agree on is that private companies should not get a seat on ICS boards, on integrated care system boards, and therefore should not be able to make decisions that affect the kind of care we get, the amount of care we get, the quality of care we get. And on the other hand, they should not put themselves in a position that privileges them in terms of providing that care. So the role of the letter that you mentioned that we are beginning to get signatories for, and we're trying to get signatories not just from traditional organizations that would sign such a letter, and you are not one of those traditional organizations, so it's already a very good thing that you signed it. And we're trying to get the King's Fund, for example, to sign, and other charities that would not traditionally sign such a letter, because we think it's a part of the ICS bill that will get universal support, and it's a way to raise opposition to the bill, right? It's obviously, I think somebody was saying in the chat earlier that this is not just about preventing private companies from sitting on the boards, right? That it's much worse, that the bill is a terrible, and I just explained in my presentation, it's such a terrible bill. But you will not be able to convince, and I've been having discussions with MPs for the last couple of months on this issue. I found it really difficult to convince them that this is a really bad thing, because they think of the propaganda around integrated care and especially in terms of how this is supposed to reverse the 2012 Health and Wellbeing Act, Wealth and Social Care Act. Right, so we have found that a good approach from a strategic point of view is to reel them in using something that everyone agrees on, and that is taking private companies off of these boards. And yes, I think that hopefully if we could get a wide enough base of support for that letter, we could use that letter as a jump-off point to oppose the bill as a whole.
Yeah, thank you, Bosco. Yeah, I mean, we all recognise that private companies have shareholders to pay, and therefore the money that is given to them to provide services is often cut because the shareholder has the handout for their percentage of the money. So we always know that where a private company is concerned, you can say a third of the money for contracts is going to a shareholder. Yeah, I hope that you have a lot of success with that. Anything else we can do to help you, you know, really push home the fact that integrated care services, if they are designed and managed in the right manner, with the public at the heart of it rather than a private contractor, then there is no reason to say that that would not work for the betterment and the improvement of, you know, of everybody who needs health and care in the UK. It is that private element that is the sticking point for us, you know, what we got out of the NHS bill. So anybody that is listening in, the NPC did put in a very, I would say probably radical and very open and honest consultation response to NHS England, to their consultation, and an even more robust and open and honest response to Matt Hancock on the NHS reform bill. And we will continue to work on that. In terms of, back to Tracy, in terms of, we have Janet, who is a member of Hornsea Pensioners, and she's saying they're just a tiny, tiny little organisation with one volunteer and they do everything themselves. Would it be possible at another time if we gave you access to the question to help them find a little bit of a way forward with that small organisation? Is that what you would do?
Oh, definitely. One of the things that LPF recognises, it's our volunteers that make LPF happen. We have Pensioners Day normally at the Theatre Royal, at the Broadway Theatre in Lewisham, and that's generally attended by 650 people upwards. It takes 55 volunteers to run that. We do the Monday project. So we're really happy to help anybody, to strengthen anyone. One of the things that I kind of got wind of is that money in terms of long-term funding, there's going to be a massive push for organisation to work with other organisations. And that's one of the things that I would definitely suggest, that you look for other organisations that have similar values as yourself in your locality, because there's strength in numbers. And at the present moment, sad as it is, it sounds, we've lost a few of our members to COVID-19. And many of our older adults feel very disenfranchised by how they've been treated in the past year and a half. And organisations like forums are so important, more than ever before. And, you know, I really commend the wonderful work that you are doing. And, you know, it's about building those networks. And what we have to recognise, some of you don't look old enough to be retired yet. we're the next in line. And that's why it's so important to do that intergenerational work, so that people don't need to wait until they're 60 and their 80s and 70s. We have to be doing this work now while we're in our 40s and 50s. So yeah, I'd be really happy. You got my details. I'm happy for my details to go out there. And if we can help, we are happy to help. We are a big organization, but there's only a small amount of people doing the work, which is often the case. But what we've got is dedicated people. You know, my boss often has this saying, I might be retired, but I'm not expired. So
that's a really good way to put it.
Yeah, last year, Jan called us up to be involved, or was it last year before? Jan called us up to be involved in one of their demonstrations up in London. And guess what? It took us 24 hours. We got the information, 24 hours. I sent out notices. And we ended up with about 8 older people out there with the placards campaigning. Don't get it twisted. These older adults will knock you for 6 if you don't be careful. They're articulate, they've got experience, and they're wise.
Yeah.
They are wise, and it will pay our community well if we paid attention. Yeah. They've been there, done it, got the t-shirt. And trust me, just to let you know, you got it. We've been sending out your campaign notices, and we're encouraging our members to sign your petitions. And we really commend the work that you've been doing, you know, and if we can continue to support, we're happy to support. So please share our details, you know, because I've got older adults here that at the drop of a hat will go out there and campaign for the NHS anytime, any place, anywhere. We did it to in terms of our campaign organisation that is in Lucian, and we will continue to do so. You've got our support.
Well, thank you so much. And I always, you know, welcome your support, and I always find my way to you by the colourful dresses and headgear that you wear, and your big ghetto blaster, you know, sending out reggae music across the whole of London. So I always know where you are. And we're so grateful for what Lewisham does for us. And it's nice to be able to return the favour today to allow you to profile your project.
Yes,
but
thank
also
you.
The fact that you're so willing to help others in the same you know, situation. And I think anyone who's as I say, from a different part of the country to London, is to get in touch with your local voluntary sector community and see what goes on. And because we do need to promote life after COVID, you know, we have the same concerns you do about people coming out of their houses, being able to come and campaign in the way we've always done it. Being online is quite, you know, alien to them, and those that aren't online, we are really struggling, you know, to keep them informed. But that's the way it has to be. But yeah, we look to the future, and hopefully we will see each other again. I've got one last question for John Bosco. I don't know, you might not be able to answer this, but I'm going to give it to you anyway. Is there anything in the NHS reform bill that gives an indication what kind of role local authorities will have, and will local authorities themselves have scrutiny panels?
Yes and no. Yes, in the sense that local authorities will get one seat on the ICS boards, as far as we know right now. We received a local authority that we were in contact with sent us the guidance they received on how to form ICS boards. And they have one seat on the board. And doctors, local, what's called LMCs, local medical committees, get a seat, and the CCG kind of infrastructure gets seats, and private companies as well. So it's they do get a seat, but the reason I said no is that they don't necessarily have very much influence with that seat. In the current system, council health and well-being boards, and in some places in the country where they also have health scrutiny committees in the council, they have an incredible amount of influence on the CCGs, partly because CCGs are quite small and they're often contained in particular areas. You might be aware in London on the 1st of April, actually it didn't just happen in London, it happened across the country. A bunch of CCGs merged together to form much larger CCGs. So in London, for example, in Northwest London, Hammersmith and Fulham joined together with a bunch of other areas around that had their own individual CCGs. And it was much easier for the council to influence the CCGs when the CCG was called Hammersmith and Fulham and the council is called Hammersmith and Fulham, right? And they represent people in the very same area. Yeah, but we're finding that it's much more difficult for them to do so now. The CCG is made up of 6 or 7 different areas of up to 1 million, 2 million people in some cases. So it's, yeah, I think their role will be significantly diminished. And I think that's one of the problems with the SES as it is.
Thank you. Well, we're nearly at the end of this session, and I'd like to thank everybody that has been involved in this, from our speakers. Unfortunately, Sir Michael had to leave. He's obviously a very, very busy man. But we will catch up with him and let him know how grateful we are. And any of the comments and questions in the chat and the questions and answers that we haven't got to, we'll put out to him. To you, John Bosco, for standing on very short notice.
Jan?
Yes, Tracy.
Sorry to interrupt. I noticed that someone's asked for the presentation. I'd be more than happy to send it to you.
Yeah, if you can send, I was just going to come to that. If if we haven't already got your slides, if you could send them to Jonathan, because everything that we've done today has been recorded. Everything will be on our website, either later today or tomorrow morning, with a link to the recording for those that would like to pass it on to people that haven't been able to come today. So thank you for everything that you've done, and thank you to our wonderful staff, Beverly and Jonathan, who, well, we wouldn't just do this without them. It's impossible. I wouldn't know how to run it, let alone start thinking how we do it. So it's down to those two and their hard work that we've, this is the 3rd session. We've got another final session next week, which I'll come to in a minute. But without them, we wouldn't be able to do this. So absolutely, everybody, thank you from the bottom of my heart for this. Just a few bits of information before I tell you about the next and the last session. Just in case people are wondering, and there's been some stuff in the chat about NHS data. People will know that we're part of the Foxglove Coalition against the government, NHS Digital, taking data without patients' consent. You also know that the government last week actually paused the data and set it back by 2 months. And that was to give them an opportunity to get in touch with patients and GPs and make them fully aware of what they were doing, what data they were taking, where that data might end up, and the safety and security of the systems within it. We haven't seen anything that's come out of that yet, so we're still waiting. But what has happened is that Clive Lewis, who is the MP for Norwich, I believe, got in touch with Foxglove and asked if they would do a presentation to MPs in the House of Commons on Wednesday. Yeah. Now the NPC will be part of that presentation on behalf of older people, and there will be Rosie Shires, who is a GP, also there. So we will be making it quite clear to any MP that comes to that meeting that we rely on them to make sure that all of the things that we believe are right and proper for people to know. I mean, you're talking about 55 million people, man, woman and child, in England, whose data will be taken on the 1st of September. And it's not very clear where the security of tenure is, the fact that they will release it to third parties. It's not just a question of whether they sell it at cost price. You don't have to sell data for it to be unsafe. All you need to do is give it to a third party whose security is completely, not there at all, and you've got leakages. And we had this with CareDoc data years ago. So we're still looking at a legal challenge if the government doesn't come forward, but it's a move forward that happened since we last sent out information to our members. And I thought it might be good for you to know that at least some MPs are taking an interest, and we'd want to see that widened out. Yeah. The NHS reform bill, we will continue to work with Leona and anyone else who wants to work with us with defending the NHS as a public accountable body rather than a quasi-private body. It's very important for our children, our grandchildren, and in some cases in our members' great-grandchildren, that NHS is there. I don't think anybody understands the difficulty that people will have if there wasn't an NHS in the form that Anara and Bevan wanted it to be. And we've been collecting some comments on that, and we're going to be trying to do a nice fancy poster to put those out there and circulate it, because I don't think there are millions in generations that have never known life without an NHS. So they need to understand where this plan is going in the next 5-10 years. Okay. So the next webinar is on the 29th of June. It is from 10:30 to 12:30, and it's called Uniting the Generations. And we have Denise Burke, who is director of an intergenerational project, and they work right across the UK all year round. So it'd be interesting to hear what they've got to say. We will have Judith Ish Horowitz, who has set up the Apple and Honey Nightingale Nursery for younger people and older people. And if anyone saw the program, I think it was last year, called 4-year-olds in a care home, that builds on that intergenerational contact, which gave the older people a huge amount of interest. Their health, their mobility, their mental health absolutely increased while those young people were there. We have James, excuse me, I can't swallow. I've forgotten his second name. Anyway, he
Lynch.
is the son, James Lynch, that's it. He's the son of Mick Lynch, who is the new General Secretary for the RMT. And he's absolutely passionate about doing intergenerational work. So we'll look out for him. And something of a departure from our ending of our annual convention. We have a lady called Joy, and there's a backstory to what she does. She is a pensioner poet and a battler rapper. So she, I can see Tracy's face, she's going, what? She has an interest with her grandson who he's into rap, yeah. So she decided that her poems could actually be transferred into rap. So that's what she does. And then she decided she'd go out and take part in these battler competitions against young people. So we're looking forward to hearing what she's got to say about her story, and also the rap that she's hopefully written for the NPC. So there we go. So we hope to see you all on the 29th at 10:30. For today, thank you very much for taking part, and take care, everybody. We hope to see you soon. We hope to be able to get out there and, like everybody else, our staff are working at home. The office is not open very much. But, we hope to get something going in shortly. So I'm going to say goodbye to everybody. I hope everybody's enjoyed it. I hope everybody got at least something out of it. I know what I've got out of this, which I always do. And we'll see you soon. So thank you so much, and goodbye.